lecture on primary angle closure glaucoma. We've gone through the other types of glaucoma, and this is the other or the third lecture we're going to give on primary angle closure glaucoma. So we have to verify what's the difference between a primary angle and a primary open angle glaucoma. So what is an angle closure? It's occlusion of the trabecular meshwork by the peripheral iridotrabecular contact, obstructing the aqueous outflow. Primary angle closure may be responsible for up to half of the cases of glaucoma globally. So if we classify angle closure glaucoma, we have three types. One is primary angle closure suspect, which are PACG, and the second is primary angle closure, which are PACs, and the third is primary angle closure glaucoma. So they're the different types. We'll go through them and we'll try to understand how they mean. So now we're just talking about primary angle closure glaucoma. Secondary angle closure glaucoma is a second category which we'll discuss in the last lecture. So first we go on to primary angle closure suspects. In this, the gonioscopy shows posterior meshwork, iridotrabecular contact in greater than or equal to 3 quadrants, but no peripheral anterior synecdoche. The pressure is normal. The optic disc and visual field are also normal. The risk of primary angle closure at 5 years may be around 30%. So this is a lot of information which I've given you. So we'll slowly go and explain what it actually means. So if we see this angle, normally you would see the angle as an open structure. So if you see the first line will be a Schwalbe's line, the next would be a non-pigmented trabecular meshwork, then you would have this pigmented line which is the trabecular meshwork, then you have the scleral spur, and then the ciliary body at the end. So when the angle is open, you would see all these structures like this. And if you take a scan or an optical scan of the eye and show the angle, here you can see the iris is convex forward at the base. And where it is convexing forward, the space between the iris and the angle becomes narrow. So this narrowness is actually shown over here probably, or more classically over here, where you can see less of the structures of the angle compared to the picture above. So these are the actual cases in which the iris is actually not sticking to the inside of the cornea or to the angle, but it is just giving a narrow space. Those are called primary angle closure suspect. The second category would be a primary angle closure in which the glaucoma shows greater than or more than 3 quadrants of iridotrabecular contact with raised IOP and or peripheral anterior synecdoche or excessive pigment smudging of the trabecular meshwork. So now you've actually got intraocular pressure being raised because more than a third of the angle is closed. But still the disease has not progressed further enough to cause any damage to the optic cup. So that is an important step. The first step, there is no intraocular pressure rise in a primary angle closure suspect. The second, you get a increase in intraocular pressure, and in the third you would get all of them: closed angle, raised pressure, and damage to the optic nerve and visual field. So here you can see these are areas where the iris is actually adherent to the surface of the trabecular meshwork. So these are called peripheral anterior synecdoche. So if you see them, this was a magnified view. If you try to see them on this view, here you can see the line of the Schwalbe's line, a line moving over here, and here you see the iris is actually come in front and the Schwalbe's line has gone behind the iris. So this is actually the place where you are getting the angle closure, and this could be due to apposition or it could be due to the formation of peripheral anterior synecdoche. Then we come on to primary angle closure glaucoma, which I already explained before, that you need to have iridotrabecular meshwork contact in greater than or equal to 3 quadrants. Now you need to have raised intraocular pressure and glaucomatous optic neuropathy, and the damage may not appear as typical glaucomatous optic atrophy. In angle closure, sometimes they tend to get more attacks of acute angle closure, so you have a sudden spike in intraocular pressure going up that causes pallor of the optic disc rather than getting that cupping of the optic disc, which is normally seen when you get a primary open angle glaucoma with slow pressure. So what is the actual mechanism? Let's go and see that thing. So there's a term which is called relative pupillary block. So we'll explain the terms here and then we'll see a photograph which will explain it much further. So when you have a relative pupillary block, that means that the physiological aqueous flow through the pupil stops because the iris is adherent or becomes attached to the lens, maybe temporarily, at the area of the pupil. This leads to a pressure differential between the anterior and posterior chamber, which causes the iris to bow forward, which is called iris bombae. Right? So let's see. This is what we were mentioning, that you have a contact between the iris and the lens, and the maximum contact of the iris with the lens is normally in a mid-dilated position of the iris. This can be a physiological pupil block, or if you have anterior uveitis, this can be due to synecdoche, posterior synecdoche, and if they are present 360 degree all around, they tend to produce this thing. So what happens, as we discussed, the aqueous builds up behind the iris on all around 360 degrees and causes the iris to bow forward like the sails of a sailing boat, which is called iris bombae. So what does iris bombae have to do with raised intraocular pressure? So what happens is you've got an iris which is bowing forward like this, and then you've got the cornea at the end. So initially the cornea was straight over here, and then if we see the cornea like this and the iris is coming in, if it was straight, then you can see the angle is pretty much open in this case. But if you have the iris coming in like this, it bows forward, it is going to rest on the inner surface of the cornea, producing appositional angle closure. Here you can see the trabecular meshwork is over here and the iris is actually come forward. And if this apposition remains for a long time and the pressure is not relieved by treatment, you can get persistent peripheral anterior synecdoche formation. The other type of glaucoma which you get is a non-pupillary block glaucoma. Far Eastern patients, deeper anterior chamber than pure pupillary block, younger than those with pure pupillary block, angle closure is not fully relieved by iridotomy, and it is due to plateau iris and a thicker or more anteriorly positioned iris. Normally you would see the iris is bowing forward or moves convexly like this, but a plateau iris will be the insertion is oblique but the front surface is flat like a plateau. So it is plateau, but the oblique origin of the iris makes it more vulnerable to contact with the angle causing angle closure. So this is the plateau iris configuration characterized by the flat or only slightly convex central iris plane. A characteristic double hump is seen on indentation gonioscopy. Indentation would be you would press the cornea in the center with a gonioscope, and then you will see double humping of the iris at the angle. The Plateau iris syndrome describes the persistence of gonioscopic angle closure despite a patent iridotomy in a patient with morphological plateau iris. So this is something which is advanced. I'm just giving an overview about plateau iris. What you need to know is at this stage is angle closure glaucoma. So if it is confusing you, you can just skip this part of the talk. Here you can see the iris is straight, but the origin is oblique, which is, this is the plateau, and but in order to make that plateau, the origin of the iris is moving forward. It is actually the root moves forward straight, and that causes its apposition or angle occlusion. So now we go on to reduce aqueous flow in angle closure. It is caused by following mechanism. So this is the outflow of aqueous is reduced, leading to raised intraocular pressure. It is caused either by apposition of the iris or degeneration of the trabecular meshwork. The pores itself become degenerated, or permanent occlusion of the trabecular meshwork by the peripheral anterior synecdoche. So I'll just explain the concept of a plateau iris. So if this is the iris like this, sorry, not the plateau, but appositional obstruction. So if the iris is like this and it bows forward and moves here and touches the inside of the cornea, that is called apposition. And if you are going to constrict that iris with pilocarpine, that pupil is going to come back into the center and that apposition is going to be released. You can check that by indenting the cornea with a gonioscope. That causes fluid to be pushed in this angle and this apposition to be opened. So you can check for appositional obstruction of the iris. But the last part, the permanent occlusion, when you have this apposition and then if you get stickiness of the iris to the inner surface of the cornea, that leads to peripheral anterior synecdoche. Then even if you put pilocarpine, this iris is stuck. You cannot open it up. Then you need to make another passage from the anterior chamber into the subconjunctival space, and that is called a trabeculectomy. So that is going to work at that time. So let's see the risk factors of this disease. Angle closure glaucoma attack is a blinding condition. A patient can go blind in few days and that blindness is permanent. So that is a medical emergency for ophthalmologists. So the risk factors is obviously older age. The lens tends to become thicker, causing the iris to move forward and increasing that appositional angle closure. Family history, people with small size eyes. Gender, female patients are more prone, and an axial length, a shorter axial length, meaning the patients with one or greater than one diopter hypermetropia are more liable to get angle closure glaucoma, because when the eye is short, small in size, all the tissues are very jumbled up together. That's why the angle is narrow as well. And obviously, as opposed to open angle glaucoma, which is more common in black race or African race, this angle closure is more common in Far Eastern and Indian and Asians. So here you can see this is a slit lamp photograph showing this is the cornea, this is the slit seen from the cornea, and this is the slit seen from the iris. And the distance between the two tells you that the area is pretty narrow near the angle. So slit lamp can tell you that this is a shallow anterior chamber. So there are different tests with which, so if you move this slit to the side and then see the iris from the side, there's a method which is called Van Herrick method that can estimate the angle as well, compared to a gonioscopy, for which you would need a contact lens. So let's see what are the symptoms. Most are asymptomatic, the patients, and intermittent and mild symptoms of blurring, like smoke-filled room, धुआं आ गया है, and halos, rainbow around lights. I sent an MCQ showing you the halos around light. This is typically seen in patients with angle closure glaucoma. So if you have gone through or sat in the winters in a car with fog, if you see lights coming from in front, you see those halos. Those are because of the fogging of the windscreen that causes the light to get scattered. Similarly, when the angle closes, the intraocular pressure rises acutely, causing edema in the cornea, producing haziness of the cornea, which produces those halos. So those were the intermittent symptoms. Or if you get an acute attack, then you get marked decrease in vision, redness, which is circumcorneal, ocular pain, and headache. Sometimes you get nausea and vomiting. We have seen patients having appendectomy because they were vomiting and they were showing nausea, but they actually had angle closure glaucoma because it could not be picked up at that time. So if it moves on forward into a vicious circle, then things get lost and you tend to miss the findings. So the precipitating factors include watching in a television in a darkened room or in a movie theater, especially a scary movie, because that will cause the pupil to go into a mid-dilated position in which you get that relative pupillary block, because the iris rests on the surface of the lens at that time, and that tends to produce a relative pupil block causing iris bombay formation. Obviously, if you dilate the pupil with mydriatics, that all the iris which is dilated will get clumped up in the angle and produces angle closure glaucomas. That is why dilating drops are contraindicated in patients with angle closure glaucoma, because they can cause blindness of the patient. The other position is semi-prone position, especially reading positions. You're lying down on your tummy. That causes your lens and iris diaphragm to actually move forward towards the angle, producing that appositional angle closure. Then you get acute emotional stress, because that causes that typical sweet mid-dilated pupil, which is essential for relative pupillary block. Then you can occasionally systemic medications such as some cough medications which tend to have some adrenergic agents which cause pupillary dilation, or some patients, they might have some atropine-like medication which cause pupillary dilation that can cause this precipitation of the angle closure. So what are the signs of chronic presentation? Visual acuity is normal unless damage is advanced. The visual anterior chamber is usually shallower in relative pupillary block than non-pupillary block. The IOP elevation may be only intermittent. Then there is a term which is called creeping angle closure, which is seen in patients with chronic angle. It slowly zips up like a zipper, and it takes a few months or years to go do that. But once it closes, you can't do much, and then you need to go for surgery. Or you can have intermittent iridotrabecular contact with discrete peripheral anterior synecdoche formation, and then obviously optic nerve signs, which would be cupping of the optic disc or pallor of the optic disc. So you can have acute presentation, which is painful, and chronic, which is painless but causing blindness slowly. Glaucoma is also called the silent thief of vision. अंधेरा आ जाता है आपकी आंखों की साइडों पे, जो कि परमानेंट होता है. इस वजह से they call it काला मोतिया, blindness or kala. So what are the signs of acute primary angle closure? The visual acuity is 660 to hand movement. The IOP is usually very high, 50 to 100 millimeters of mercury. Obviously that produces a very painful eye. Conjunctival hyperemia with violaceous circumcorneal injection. Corneal epithelial edema. The anterior chamber is shallow and aqueous flare is usually present. An unreactive mid-dilated vertically oval pupil is the characteristic pupil which you see in patients with angle closure glaucoma. So when the acute attack resolves, you get hypotony because the ciliary body goes into a shock. That's why. And then it tends to recover and then again produces raised intraocular pressure. You can get folds in decimated membrane, optic nerve head congestion, or which you look like the disc would look like it is swollen. And then you can also get choroidal folds. The late signs of resolved APAC is iris atrophy with a spiral-like configuration or a whorled appearance, glaucom facum and other forms of cataract, irregular pupil due to iris atrophy, sphincter dilation damage, posterior synecdoche formation because angle closure glaucoma produces uveitis. Optic nerve may be normal or exhibit pallor and or cupping. Sequelae of APAC. The greater the duration of an attack, the extent of post-APAC PAS is more. The lower the likelihood of IOP control with medication. Because once you close more than 2/3 of the angle, the eye cannot maintain an intraocular pressure and the eye will have a constantly raised pressure, thereby producing damage to the optic disc. Here you can see the cornea will typically look, if you're looking through this ground glass appearance, and this type of cornea will give you that halos around light. This is the typically vertical oval pupil which you see in patients with glaucoma, and here you can see the reflex of the cornea is slightly hazy. Here it's not, it is dull reflex of the cornea. So look at the corneal reflex. This patient has got circumcorneal congestion and he has got corneal haziness or corneal edema, mid-dilated pupil, and if you would look to a slit lamp, you will get shallow anterior chamber. The other way to see a shallow anterior chamber is, as I sent you an MCQ yesterday, you shine a torchlight from the side, and normally if the iris configuration is flat, if you shine the light from the temporal side, the nasal and the temporal iris will be equally illuminated. But if you have an angle closure glaucoma, the iris is obviously bowed forward like this. So if you shine a light from the temporal side, it is going to shine on the temporal part, but the nasal part will be in a dark shadow like a crescent. So that is how you would see for that test. These are the other changes which you see. You can see these fine opacities on the anterior capsule of the lens, and these are called glaucom flecken. That happens because of acute necrosis of the epithelial cells of the anterior capsule of the lens. Here you can see the patient is presenting with pallor of the optic disc, the cup to disc ratio for which we see the pallor, and then where the vessels are bending. So if I make a circle like this over here, so this patient would have probably 0.5 cup disc ratio of 0.5. So what investigations when you could do? Anterior segment ocular coherence tomogram. It gives you a structure of the anterior chamber. Anterior chamber depth measurements, you can do that with a biometry or a scan, and you can do actually the calculation of the lens if you want to do a lens extraction. And we'll go through why is lens extraction a procedure to treat angle closure glaucoma. That looks a bit odd, that why would you remove a lens to control glaucoma. Then you can do a posterior segment ultrasonography and provocative tests like pharmacological mydriasis or darkroom prone provocative test. In darkroom prone provocative test, you would have the patient lie down on his stomach, and then would be in a dark room, so the pupil is mid-dilated, and by lying prone, the iris and the lens diaphragm move forward, and the patients with shallow chambers can have a provocation of their acute attack. So what are the differential diagnoses of acute IOP elevations? It can be due to lens-induced angle closure glaucoma, which is also called phacomorphic glaucoma. So the phacomorphic means the lens is normally biconvex, so with increasing size, it tends to become more convex. So it produces if the lens is like this and it becomes more convex like this, because of its thickness, it will cause iris to move forward and occlude the angle. Malignant glaucoma is an entity in which fluid aqueous is misdirected into the vitreous, and instead of coming forward through the pupil into the anterior chamber, it goes back into the vitreous and accumulates there, causing a malignant glaucoma. Then you've got neovascular glaucoma. New vascles form on the surface of the iris and then go into the angle of the iris, producing angle closure. Hypertensive uveitis. You can have anterior uveitis in which you get thick proteins in the anterior chamber which cause the trabecular meshwork to clog up and produce a hypertension, meaning raised intraocular pressure. Scleritis. Pigment dispersion, meaning if there is pigment being released from the surface of the iris and that occludes the angle trabecular meshwork, that will cause glaucoma as well. Similarly, pseudoexfoliation is a fibrillary material which is formed with age in patients, and that also causes occlusion of the angle. And then retroorbital lesions or orbital lesion can obviously push the eyeball and its content forward and cause intraocular pressure rise. So in the end, we would come on to the treatment of angle closure glaucoma. So if you have a patient with primary angle closure suspect, what you want to do is, this is the iris and you have a tendency that the iris bows forward due to pupillary block, a relative pupillary block over here. So what you want to do is you make another window, you make another opening in the iris through which, even if you have relative pupillary block at this area in the center, the fluid will actually go and move out through this area in the periphery and prevent that. So that is a preventive procedure. But if significant iridotrabecular contact persists even after iridotomy, you can observe or you can do a laser iridoplasty. Laser iridotomy is done with a YAG laser, which causes photodisruption. Laser iridoplasty, in which you would use an argon laser that produces small burns on the periphery of the iris, causing the peripheral iris tissue to shrink. And then that iris shrink tissue would cause the iris to move away from the angle. So that is iridotrabeculoplasty. In iridotomy, you would actually make a hole in the iris in the periphery. And then long-term pilocarpine. I put a question in the MCQs that the pilocarpine causes opening of the trabecular meshwork because it is going to cause pupillary constriction, and that pupillary constriction pulls the base of the iris in towards the center, causing and pulls on the trabecular meshwork, causing it to open. So that is, and then the second treatment would be for primary angle closure and primary angle closure glaucoma. So the management is as for PACs, but medical treatment as for primary open angle glaucoma. Means if you have primary angle closure glaucoma and more than 2/3 of the iris of the angle is closed, then you would need to do or use anti-glaucoma drops, as you would use aqueous suppressants or pilocarpine. So here you can see a patient having peripheral anterior synecdoche over here. This is a pigment shown in the angle in this patient. So a typical question or one skill you need to develop if you are graduating from ophthalmology, or even if you know nothing about ophthalmology, one thing you should know if a patient presents to you with angle closure glaucoma. So what do you want to do? Because he's going to go blind if you don't help him. So what do you want to do? Ask him to lie down supine, facing up. Give him, so if the patient's intraocular pressure is 50, the aqueous humor production is too much. The production is, I think, steadily what it should be. It's not more than what it should be. It's just that it's not getting drained because occlusion of the angle. And at 50, the iris sphincter is ischemic, becomes ischemic, and cannot constrict. So pilocarpine does not work at that pressure. If the pressure is very high, so you can give them oral acetazolamide, probably might not work. So IV acetazolamide if it is more than 50, and oral if it is less than 50. If usually IV acetazolamide is not available in Pakistan, so what we tend to give is intravenous mannitol 200 ml. So what that does is it is actually going to cause shrinkage of the vitreous body. So it takes out fluid out from the vitreous cavity in the gel, compared to it's not a suppressant of the ciliary body or does not cause anything to the angle. So it is, but the main issue is you have to be careful because it causes initially volume overload in the body because it is producing oncotic pressure with which it pulls out fluid. But if a patient has hypertension, they can get worsening of hypertension. So if you want to give that, you need to know about that. And once you've given that, you need to be careful, and the patient should be near a toilet because they're going to feel a lot of urge to go to the toilet to pass out urine. The next step would be to use apraclonidine, which is or 1% timolol 0.5% drops, which tends to reduce the aqueous production. And you add 1% prednisolone, which is a mild steroid, to reduce the inflammation, or dexamethasone 0.1%. Then the most important drops, which I ask the student all the time, which is the treatment of choice for angle closure glaucoma, that is pilocarpine, because that is the only drug that is going to open that angle by causing the pupil to constrict and pulling the iris inside from that appositional stage. So you put the drops at half-hourly interval, and you put another drop in the other eye as well until you do a gonioscopy. In resistant cases, you can do a central corneal indentation to cause that aqueous to forcefully go into that angle, that apposition to get released. And you use further pilocarpine 2%, timolol and apraclonidine and topical steroid, and mannitol over 1 hour. Then once you've got the pressure down, the cornea clears up, you can go and do a iridotomy, laser iridotomy. Sometimes you can actually puncture the anterior chamber with a very small 30 gauge needle, which is called a paracentesis, which is usually a self-sealing incision. If things do not settle this way, then you have the other option is to do a permanent peripheral iridectomy. So you actually make an incision in the periphery, get hold of the iris with a tooth forceps and cut it with a scissors, which makes a triangular opening at the base of the iris, which is called an iridectomy, which you also see in patients when they undergo trabeculectomy. Then lens extraction, as I talked about. So if somebody's got a lens which is thickened in size, that is causing the iris to move outward and producing appositional angle. So if you remove that lens from inside the eye, that iris which is being convexed forward, bowed forward due to the lens, it will fall back because obviously the thickness of an intraocular lens is much less compared to a cataractus or even a non-cataractus lens. And then you can go to sometime if there's peripheral and anterior synecdoche formation, when you form the anterior chamber, you put viscoelastic gel inside the angle to cause that iris to separate from the trabecular meshwork. Then the second last option is to do a trabeculectomy, in which you make a space or a channel from the anterior chamber into the subconjunctival space. I will explain that in the next lecture. Or the last option is you actually ablate the ciliary body, or you produce cyclodiode or cyclocryotherapy is one option, in which you would cause destruction of the ciliary body so the aqueous production is permanently stopped. So that is one option. It is only done when the patient has got a blind eye or very poor vision, because one problem with that is if you cause the ciliary body to shut down, sometimes it can be shut down permanently, and that permanent thing can cause hypotony, and that can lead to phthisis bulbi or a shrunken eyeball in very minute number of patients. So it is reserved right to the end when the vision is very less. So this is what I told you about. This is compressing the globe in an acute attack, causing the aqueous to go into the angles and open that apposition, because you need to reduce that apposition so that you don't get formation of peripheral anterior synecdoche. So this is the peripheral iridectomy I was talking about. What it's doing is